Okay, in chapter 22, we're going to talk about the obstructive and pulmonary disorders. Obstructive pulmonary disorders are manifested by increased resistance to airflow, right? Obstructions of some sort. Now, they're classified by either obstructions that affect the wall of the lumen, obstructions that lead to an increase in pressure around the outside of the airway lumen, or obstruction of the airway lumen itself. So we'll talk about those conditions that fall under these three main classifications. And the first one we'll talk about is asthma. Now, asthma is an airway obstruction that's reversible, not always completely in some patients, but it's basically chronic airway inflammation that leads to increased airway responsiveness to a variety of stimuli. It occurs in 5 to 12% of the U.S. population, so it's fairly common. You're talking about 1 in 20 or 1 in 10 of individuals between that range has asthma of some sort. And it's one of the most common chronic diseases of children. You know, typically think about asthma as being a childhood disease, but there are adult types of asthma as well that we'll talk about. So there are two main types of asthma. We got intrinsic versus extrinsic asthma. Intrinsic asthma is non-allergic asthma, and it has more of an adult onset. Extrinsic asthma is allergic, and it has a pediatric onset. You know, when we talk about allergies, we're talking about type 1 IgE-mediated hypersensitivities, which typically have a pediatric or childhood onset. The intrinsic forms of asthma are often idiopathic and non-allergic. They have poorer outcomes and have an adult onset. So extrinsic asthma, you guys, 1/3 to 1/2 of asthma cases. Remember, it's an IgE-mediated response to some sort of allergen. You know, people are allergic to different things, but if they're inhaling that allergen, that can lead to asthma. So the treatment of extrinsic asthma is going to be pharmacologic therapy, you know, allergen-specific immunotherapy, or even environmental control. If you can avoid that allergen or allergic trigger, then you can help reduce the symptoms of your asthma. Intrinsic asthma can develop in middle age. It has less favorable prognosis. It can even occur in people with no histories of allergy. Respiratory infections or psychological factors can be contributory. So stress can precipitate this sort of intrinsic or adult form of asthma. Otherwise, respiratory infections can also lead to this sort of asthma-type symptoms as well. And what you might find then, you guys, is that allergen-specific immunotherapy and environmental control are not helpful. So what this suggests then is it's not extrinsic, right? If it were due to something that's in the environment that you're inhaling, you should expect then that changing someone's environment or having allergen-specific immunotherapy, like blocking an allergen, you know, using an antibody, that should reduce the symptoms of asthma in someone with that form of asthma or extrinsic asthma. But with intrinsic asthma, changing their environment and doing allergen-specific immunotherapy doesn't change the symptoms of their asthma. So it has more odd types of pathologies here or manifestations, but typically adult onset with less favorable prognosis. And the first subtype we'll talk about, you guys, is the exercise-induced asthma. It's common in children and adolescents. What we find is that during exercise, it leads to asthma. Okay, so these bronchospasms can occur within the first 3 minutes of exercise, and it can resolve within 60 minutes after exercise. And it's believed to be caused by water loss. During exercise and you're breathing or ventilating very heavily, you're exhaling a lot of water. We know that we exhale a lot of water because on cold days you can see your breath, right? Well, when you see your breath, you're basically looking at your own water vapor that you're exhaling. It's not like on a cold day you're exhaling more water vapor than you normally would. It's just that now you can see your water vapor because it's freezing in the air as you exhale it, right? Which makes it look white. So when you say you see your breath, that's all the water vapor you're breathing out. Well, imagine if you're exercising and you're exhaling a tremendous amount, right? Then you're also losing a lot of water vapor, which can dehydrate your airways. So it's the dehydration of that airway that increases the osmolarity of your respiratory mucus because it becomes more concentrated when you have less water. This stimulates things like basophils and mast cells to release their inflammatory molecules. That leads to things like smooth muscle contraction and inflammation, which causes an increase in airway resistance, which is this exercise type of asthma. This is the type of asthma that I've had. It's the geekiest type of asthma, right? Like, oh, I'm allergic to asthma. Well, I'm sorry, I'm allergic to exercise. But it's something that I've struggled with, and it still kind of precipitates now and then, especially in Denver. It's really dry here. You know, if I'm exhaling a lot, and then my respiratory membranes start drying out, I can feel my airways kind of tighten up. And in fact, sometimes there's so much constriction, it actually is kind of painful to breathe. So just got to puff on that inhaler before exercise. Let's do this, you guys. So with occupational asthma, this is where it's a form of extrinsic asthma where someone's allergic to something that they work with. You know, I think we've talked about how I think I'm allergic to this dry erase marker junk. You know, as an occupation of teaching and working with this dry erase marker stuff, every time I start using these dry erase markers or dealing with these whiteboards, and I get this on my hands, I start to itch a lot. And if I inhale it, you know, my lungs start kind of tightening up. I also think I'm slightly allergic to formaldehyde because I work with so much formaldehyde and dissection that my lungs start kind of tightening up when I'm around a lot of formalin. But with occupational asthma, you guys are going to see like positive, skin test reactions to different proteins or things that you might find in the work environment. You can conduct different tests to determine what someone's allergic to, so skin tests. And this has a tendency to progress to more severe attacks upon subsequent exposure. So someone might be slightly allergic to formaldehyde initially, but if they're around it, like in their career every day for maybe 5 days a week, for years, then they can become more and more hypersensitive to that, and that can lead to stronger and stronger attacks. In fact, I know somebody who used to teach cadaver lab, and now he can't because he's developed such a strong allergy to formalin. He can't even be in the same room as like a cadaver that's fixing formaldehyde. So it's kind of interesting. So sensitization is ineffective. Like being exposed to that allergen is not going to decrease your sensitivity. So, sort of counterintuitive. Now, drug-induced asthma, you guys can produce symptoms of from mild rhinorrhea or even respiratory arrest. People can be allergic to things like aspirin or non-steroidal anti-inflammatories, and that can trigger asthma attacks. Other food additives as well, you guys, like tartrazine, which is yellow dye number 5. You find that in different foods like Mountain Dew, monosodium glutamate, sodium or potassium metabisulfite. In fact, you find sodium or potassium metabisulfite in a lot of things like fruit juices, things that can ferment, because this potassium metabisulfite is a preservative that they add to prevent fermentation of the food, right? If you just leave fruit juice out, yeast is going to cause fermentation of that, and you're going to end up with like wine or be like a really bad wine, right? Well, they add this metabisulfite here to prevent yeast growth, but sometimes people can be allergic to this stuff, like these food additives. Even hops in beer, because hops are basically like the flower of the vine, and they're full of pollen, which ends up in the beer, and people can be allergic to that as well. So just something to keep in mind. There's a lot of fear surrounding MSG, though, right? Like people are really afraid of MSG. But what's interesting is there's not really any good science to suggest that MSG causes your blood pressure to skyrocket. In fact, this whole MSG scare came about in the 70s, where there's a doctor who every time he ate Chinese food, he ended up breaking out in a rash and getting kind of a reaction. So they call it Chinese food associated syndrome, right? Well, he tried to investigate it further, and he suspected it related to the MSG. Well, the media caught on with this, and just based on this one person's opinion, the media started saying, "Oh, avoid MSG," right? There's a big scare about MSG, which even carried into the 90s too. There's not really a whole lot of good data, though, to suggest that MSG is necessarily all that bad for you. Although there's some people who claim that they can feel that, when there's MSG in their food. And I'm not saying that that's incorrect, but it's just there's not a lot of good data on that. So it's just something to keep in mind. Now, for asthma, you guys, like we're talking about here, some of the immunohistopathological features, we'll see is an edema of the airways, or just sort of a thickening of the airways. We'll see mast cell activation, so you see an inflammatory response. We'll see infiltration by neutrophils, eosinophils, and lymphocytes as a consequence of that inflammatory response. And inflammation of the airway can lead to bronchospasms, mucus plug formation, even airway remodeling, where over time the airways can become thicker as a consequence of tissue remodeling. So chronic asthma, not just acute attacks, but chronic asthma can lead to thickening of the basement membrane, thickening of the cartilage in the airways, thickening and overgrowth of mucus cells, all of which cause your airway lumen to narrow. I think we see that on this slide here. So on the left, we're seeing a normal airway where you have some mucus glands, you got some cartilage here that's going to support the airway, you have some smooth muscle in here, and then you have your pseudostratified ciliated columnar epithelium. And the airway has a fairly large lumen here. Now with chronic asthma, what we can see then is we can see airway remodeling, where the cartilage gets thicker, smooth muscle gets thicker, you have more mucus glands. All of this causes the airway to become smaller here, the lumen becomes smaller, and you can see too much mucus production. This is all a consequence of that chronic inflammation. So what this means then is it's more difficult then to open up their airways. So due to this remodeling. So chronic asthma actually can be fatal. We usually think about asthma as being sort of a more temporary benign condition, but people do pass from asthma attacks. It can happen. So what this slide is showing you guys are some different asthma medication sites. This should be a nice review for pharm. But what this is showing then are all these different medications that target different aspects of the inflammatory pathways associated with asthma. And if you can block these inflammatory pathways, then you can prevent that those changes that lead to narrowing of the airway lumen. Now, don't worry about memorizing each of these specific drugs for patho, but just something to keep in mind, you guys, like when you're talking about different drugs for respiratory diseases in pharm, you can come back to this slide and think about what's targeted with respect to inflammation with asthma. Now, moving on to bronchitis. Bronchitis is where you have acute inflammation of the trachea and bronchi. So the different causes could be like either viral or non-viral. It could be due to heat and smoke inhalation, inhalation of irritating chemicals, or even allergic reactions to different substances. In asthmatic bronchitis, we call it a swelling of bronchial mucosa. Occurs in children, can lead to obstruction, respiratory distress, and wheezing. Now, the pathogenesis of bronchitis is where airways become inflamed and narrowed from capillary dilation. You get swelling from fluid exudation. Exudation is just sort of, remember, the fluid that leaves, capillaries that are more leaky during the inflammatory response. You can see an infiltration with inflammatory cells, more mucus production, a loss of ciliary function, so you're going to see an overproduction of mucus and an accumulation of mucus in the airways, and even loss of portions of ciliated epithelium over time if this is like chronic bronchitis. Some of the causes of chronic bronchitis can be things like cigarette smoking, airway infections, some people are genetically predisposed, or even inhalation of physical or chemical irritants. Now, for chronic bronchitis, this can lead to inflammation and swelling of the bronchial mucosa, leading to scarring. It can lead to hyperplasia of mucus glands and goblet cells, causing an increase in bronchial wall thickness, which can decrease airway airflow, destruction of bronchial walls, or even pulmonary hypertension from destruction of blood vessels serving specific parts of the lung. Emphysema we call type A COPD, and this is actually going to be a type of pathology where you have obstruction that's related to the loss of lung parenchyma. Lung parenchyma is just lung tissue. So COPD is due to loss of this lung tissue. And what we find that are destructive changes of the alveolar walls without fibrosis. Like you don't see the fibrotic scarring that you would see like with traditional scar tissue. Instead, what we see here then is a slow destruction of alveoli. So that alveoli over time become less and less abundant. Well, we know that the alveoli is where gas exchange occurs. And if you see the slow destruction of this, then you're basically removing those places where gas exchange occurs. So over time, you're going to see a difficulty with proper gas exchange. So the damage here is irreversible. And it's associated with chronic bronchitis. The most common causes of COPD, though, are in smoking, right? So if someone's smoking 670 more packs per year, that can put them at higher risk for COPD. Exposure to air pollution. They're suspecting that in some of these developing countries that have a lot of air pollution, you see pictures from like Beijing, right, where it's like there's so much air pollution it looks like fog. They're suspecting that years from now, their population is going to suffer from a lot of pulmonary disorders, which we probably did see when Western nations were developing, like during the, the Industrial Revolution. It's just that these weren't really documented, well documented back then. Otherwise, certain occupations, like if you're a miner and you're exposed to a lot of inorganic dust particles, if you're a welder, also exposed to a lot of basically metal vapor, working or with asbestos. Asbestos, by the way, is one of those naturally occurring minerals, and this is one of those things that's all natural, right? You guys, it's asbestos. It's all natural. It comes from the earth. Everything that comes from Earth must be good for you. No, that's not true, right? So asbestos is one of those things. So it's a mineral. It's a really good insulator because it doesn't conduct heat really well. So back in the day, people used to dig this stuff up out of the ground. It looks like kind of like a hairy type of mineral. Well, you can pack your walls full of this mineral, and it keeps the heat inside your house very well. It also keeps the cold out, right, or the heat out. However, this asbestos, because it's inorganic, it's difficult for your immune system to break down. So once inhaled, it leads to this inflammatory reaction that leads to tissue destruction. And with enough exposure, it can lead to COPD or emphysema. Or there's also genetic conditions like alpha-1 antitrypsin deficiency, which also puts someone at a risk factor or at risk for emphysema. Now, the pathogenesis of emphysema we'll see here is a reduction in pulmonary capillary beds, so decrease in blood flow to the lungs, as well as the release of proteolytic enzymes from neutrophils. These proteolytic enzymes break down the lung tissue, but that doesn't lead to the production of fibrosis. Okay, so it doesn't cause the lungs to become fibrotic and hardened and scarred. It just slowly causes destruction of the lung tissue from the inside. So you eventually leads to the loss of elastic tissue. We see that alveoli become much larger so that air can get trapped in these distal alveoli because of less elastic tissue. You don't see as much recoil, so air is not really forced out of the lungs that easily. And the loss of alveolar wall causes air to be trapped in large sacs in the lung called bullae, which are these large, thin-walled cysts in the lungs. And so all of these factors ultimately lead to a trapping of air in the lungs, which increases the residual volume and therefore decreases how well someone can ventilate. Okay. Now, what this slide is showing are some of the clinical manifestations of emphysema. What we'll find that is that you're typically going to see a large barrel chest. So the chests are going to become hypertrophied because it takes a lot more muscular activity just to ventilate. Okay. So you get this large barrel chest because their intercostal muscles work more strongly. Their ribs end up kind of expanding outward as well. And the respiratory diaphragm has to work much more strongly just to function. Accessory respiratory muscles, like on the neck, you guys see how his neck looks kind of more muscular here with respect to the rest of his body? Well, some of the accessory respiratory muscles, like your scalenes, your sternocleidomastoid, those are also used to ventilate. Well, if you're struggling to breathe, those muscles also get larger. So you're going to see that someone with emphysema will not only get a large barrel chest, but their accessory respiratory muscles, like their scalenes and sternocleidomastoid, also will hypertrophy because they're struggling to ventilate. Pursed lip breathing, again, because they're having difficulty ventilating, that they're kind of like almost like they're sucking through their lips, right? Leaning forward to breathe, because apparently that helps them ventilate in some way. That barrel chest we mentioned. Digital clubbing, which we'll talk about, as well as shortness of breath, right? Because they have difficulty with ventilation, they're going to be hypoxic, and they're going to have dyspnea from that. So bronchiectasis, you guys, is basically an obstruction of the airway lumen. It occurs from dilation of the bronchial wall. It's where you have these large sort of sacs that form. It can be either acquired or congenital, and it's both obstructive and suppurative, pus forming. It's associated with cystic fibrosis, and you actually find this in high risk in children. Now, it can come about from recurrent infections from the bronchial wall, which causes these dilations, or thickening of the bronchial wall. Inflammation leads to destruction, and this destruction process leads to loss of ciliated epithelium, which causes basically mucus and pus to accumulate in the bronchus. So this is what these bronchiectasis look like here, you guys. So you find these sort of distal sort of sacs that form. Air gets trapped in these sacs. Also makes it more higher risk for infection because mucus gets trapped in here, and with the loss of ciliated epithelium, it's difficult to remove that mucus from your airways. This also leads to a decrease in ventilation because it makes it more difficult for air to flow. And like emphysema, what this can lead to, one of the signs we call is digital clubbing. So normally your fingernails should be fairly flush when you try to put your fingers together. Okay, so they shouldn't separate a whole lot. But under chronic hypoxic conditions, it can lead to what we call digital clubbing, where the fingernails grow in a more rounded fashion. Instead of the fingernails being sort of flush, they'll be much more rounded, much more clubbed. So when you try to put your fingers together, you end up getting a large angle at your fingertips. We call that digital clubbing. That's one of the signs of emphysema and bronchiectasis because of this chronic hypoxia that occurs. The nails don't grow properly. So kind of an odd manifestation of a pulmonary disorder. You can see this on your fingernails. But But you guys notice how the fingernails are more clubbed here instead of being flush? So this is sort of a more normal nail angle. You can see a little bit of mild clubbing here. In fact, I think I have a little bit of mild clubbing just looking at my nail right now. That probably comes from my history of asthma, right? But if you have something like emphysema or bronchitis, you can get more advanced clubbing where the fingernails are very clearly rounded. In fact, they almost look like semicircles. And so when you put your fingernails together, then they can't be together flush and end up kind of being more separate. That is one of those signs associated with chronic pulmonary disorders. So it's kind of interesting. Now, bronchiolitis is widespread inflammation of the bronchioles due to infectious agents. Can be related to allergic reactions, but respiratory syncytial virus, or RSV, is one of the most common causes. You're going to find this in children less than 2. Occurs in the winter and spring months because that's when this virus is most prominent. And it can occur in adults that are exposed to smoke, toxic fumes, or immunosuppressed. For cystic fibrosis, you guys, we talked about this earlier because it's an autosomal recessive disorder. And it was a disorder that was associated with a mutation in a chloride transporter. So we said that there's a CFTR gene, or chloride transporter. If that gene were mutated, so you had a mutant allele, if you only had one of those mutant alleles, that's not enough to express cystic fibrosis. You would need to inherit both mutant alleles from either parent and have 2 defective copies of this allele or gene to express cystic fibrosis. But it's one of the most common autosomal recessive disorders of individuals of European descent. Okay. Now what we find then is that due to a disorder of this chloride transporter, they don't make mucus very well. In fact, the type of mucus they make is more thick, sticky, and tenacious. Instead of being more watery and viscous, it's like a really thick type of mucus that accumulates in their airways. And if that mucus is really thick, it's also difficult to remove. Okay? So the median survival rate age for cystic fibrosis, you guys, is only 31 years old. So you can expect that half of people who are born with cystic fibrosis will pass before 31, and the other half will pass at some age after 31 years of old age. So it's kind of interesting. Now, it comes from a dysfunction of the CFTR gene here, and if you're inheriting both defective genes here, what ends up happening then is you can't transport water very well across your epithelial cells, so the mucus that you're making is more thick, tenacious, and viscous, or actually more kind of sticky. So it's much more difficult to remove from your airways. You might wonder, well, why would that lead to death? Like, how would having thick mucus in your airways could be potentially more fatal? Well, that mucus can harbor bacteria, so they're much more prone to pulmonary infections. And that mucus itself, if it accumulates, can obstruct airways, which is why we're putting this as an obstructive disorder. Okay, so causes airway obstruction, could lead to atelectasis, which is partially or fully collapsed lung, and can also provide a medium for pulmonary infection. Now, acute tracheobronchial obstruction is basically just where someone inhales a foreign object and it just kind of, acutely block their airway there. So this can be caused by things like aspiration of a foreign body. It's most often inhaled in the right lung. Why are foreign objects most often inhaled in the right lung? The bronchus is steeper and wider than the left bronchus, right? So the right main bronchus is steeper and wider. So it makes sense. If you're inhaling something going to the trachea, it's got 2 places to go, to the left or to the right. Well, it's going to go most often to the right because it's steeper and a wider space there, the right main bronchus is. So if you inhale like a marble or something, it's most likely going to go into your right lung. Now, these tracheobronchial obstructions can also come about from laryngospasm. So your larynx, if it starts spasming, the epiglottis can close, which can also be an obstruction itself. So it can make it more difficult to ventilate if your epiglottis is just randomly shut. Okay. Can be also caused by epiglottitis, so inflammation in the epiglottis can block that airway, or compression of the bronchus and trachea from like a tumor or enlarged lymph nodes. And the obstruction may be complete or partial, right? And the severity of this obstruction is going to depend on what part of the airway is being obstructed. If it's the trachea that's obstructive, you're not going to get. If it's the trachea that's completely obstructed, you're not going to get adequate airflow, right? If it's a distal bronchus that's obstructed, you might not see as dramatic signs and symptoms, if that makes sense. Croup syndrome is basically an infectious agent that will infect the subglottic area, and it leads to edema here that basically causes this barking cough, and they call it croup cough. It kind of sounds like a bark, which is like a small dog barking. And you find this in children with a history of upper and lower respiratory tract infections. It won't cause drooling, but you're going to see croup under severe respiratory infections. Now, epiglottitis is where you have basically inflammation of the epiglottis. Could be due to infection. We call this a subtype of croup, common in children 2 to 4 years of age. The reason why children are more at risk for these respiratory infections is that their immune systems aren't fully developed yet, right? So they're more prone to these respiratory infections. But one of the common types of organisms that causes epiglottitis is Haemophilus influenza, right? Which there's a vaccine for now. Now, some of the diagnostic tests that can be performed to figure out if someone's ventilating appropriately is like pulmonary function testing, or PFTs. This requires spirometry. Remember, the spirometer is going to measure airflow into and out of your lungs. And we talked about these spirometric data earlier. We talked about things like tidal volume and inspiratory reserve volume or expiratory reserve volume or vital capacity. Well, with the spirometer here, if you measure all those different variables, it can tell you about ventilation into and out of the lungs. And so we can look at those data to figure out if they have normal ventilation, restrictive, or obstructive ventilation. So what this slide is showing here, you guys, in the green trace is a normal ventilation curve. So in 4 seconds here, you can see that someone can actually have, a complete inhalation, right, in about 4 seconds. And then it kind of plateaus because they can't inhale any farther. But with a restrictive pulmonary disorder, they will max out on how much they can inhale within the first few seconds. In fact, they won't even get to a normal level of inhalation, which means that for the restrictive pulmonary disorders, you're going to see that their inspiratory reserve volume will be lower than normal. They'll be outside of the normal limit for inspiratory reserve volume. They can't get to the same degree of inspiration as the normal level. That differs from the obstructive pulmonary disorders like we just talked about, asthma, bronchitis, right, epiglottitis, and different disorders that can affect the airway lumen. Those are obstructive. Then what we find that is that you can get to close to the maximal level of inspiration. It just takes you longer to get there, right? So what's interesting too, you guys, is you actually can start to see pretty dramatic differences even in the first second of inhalation here. You can see that with a normal breath, there's a really rapid increase in lung volume. With an obstructive pulmonary disorder, it's much more slow increase. And restrictive, it's rapid, but it's difficult to see, early on whether you're actually going to get to your sort of peak inspiration volume here. So one thing that's important to note, you guys, with the obstructive disorders, you can get to your maximal inspiration. It just takes you longer to get there. With the restrictive pulmonary disorders, you can't get to the maximal inhalation, okay? But with normal, that's what we're seeing here. This should be occurring in the first 4 seconds. Because we're talking about where people take a really rapid, deep breath, right? That's far less than 4 seconds, what I just did. That might have been 1 to 2, okay? And you could keep going if you try. So it doesn't take very long to figure out if someone's got normal, restrictive, or obstructive pulmonary disorder.